Hey everyone, in this series of lectures we're going to be discussing patellofemoral pain. The objectives for the lecture will be to distinguish between normal and abnormal anatomical and biomechanical considerations for patellofemoral pain. Identify risk factors associated with patellofemoral pain, determine signs and symptoms associated with patellofemoral pain, and understand an evidence-based approach for the management of patellofemoral pain. We're going to start out this section by looking at some of the anatomy and the biomechanics of the patellofemoral joint and the knee itself. So it all starts with the patella when we're discussing patellofemoral pain. So the patella increases the moment arm of the quadriceps. It provides bony protection to the femoral condyles. It also prevents compressive forces on the quadricep tendon. There's a trochlear groove that the patella rests on, and it slides up and down superiorly and inferiorly as you go into flexion and extension. The quadriceps muscle obviously is attached to the patella through the quadriceps tendon, so that's the primary muscle group that's going to be associated with some of this patellofemoral pain. The IT band is lateral, and then the hamstring, specifically the biceps femoris, has been associated with some patellofemoral pain presentation. So each of these structures plays a significant role in patellofemoral pain, and our management strategies might adjust depending on which structures are involved. Now, I will say it's very difficult, and the majority of the time we're going to be unable to identify the specific structure involved. However, sometimes we are able to pinpoint that. To briefly review patellofemoral arthrokinematics, the patella lies within the quadriceps tendon. It increases the mechanical advantages of the mechanism, provides stability, and it minimizes forces placed on the femoral condyles. So it serves many different purposes, and a lot of it comes down to the mechanical efficiency of knee flexion and extension. The patella increases the angle of insertion for the quadriceps. It allows for increased torque producing capability of the quadriceps. There's a lot of physics that can go into it, but all you need to know is that the patella allows for increased torque capabilities for the quads. If your knee is in a rested position closer to extension, you can change the position or glide the patella in multiple different directions. So flexion and extension allows for that superior and inferior glide. If you're going through mobilizations, you can also do medial and lateral glides. You can do medial and lateral tilts, medial and lateral rotation, and then anterior and posterior tilts. Here are a few pictures just looking at the things we just discussed with the different glides and different positions of the patella itself. You can see different lateral medial glides and then the tilts associated with those. You can also see in the bottom pictures the orientation of the patella. They label it normal orientation and lateral medially rotated. Now, I think that's more of just an observation. We're not going to use that in our treatment for patients with patellofemoral pain because it's not really associated with patellofemoral pain. However, I think it's good to have a basic understanding of the human body and the anatomical position of the joints. So being able to appreciate these different positions can be helpful. During open chain movements, the patella is moving on the femur, and during closed chain movements, the femur is moving on the patella. Now, patellar movement is typically described as the patella moving on the femur, even during closed chain movements. However, it's important to make that distinction in understanding which bones are moving on which. The relative patellar position and area of contact with the femur changes with extension and flexion. The more flexion, the more distal the patella is along the femoral condyles, and vice versa. So with more extension, the more proximal the patella will be. The resting position of the patella can be described in a couple different ways. Patella alta is considered to be a high riding patella, and patella baja is considered to be a low riding patella. It has been found that if you have patella alta, it's usually due to a longer patellar tendon, and that may increase the risk of subluxations of the patella and dislocations of the patella. For patellar baja, they have theorized that it may increase the likelihood of excessive compressive forces on the patellofemoral joint due to the resting position and the mechanical advantage of the quadriceps pulling through that patella, just pushing it into different positions, leading to higher compressive forces. Now, I don't know if this has been studied very thoroughly, so it's mostly just theory at this point, based on biomechanical principles. The forces on the patella change based on two primary things. The first being the amount of force going through the quadriceps muscle, pulling on the patellofemoral joint, and the other would be the knee flexion angle. Some studies have shown that max torque occurs between 45 and 70 degrees of knee flexion. And then the other area of interest here would be the patellofemoral joint reaction force, as this kind of describes how much force is going through that joint during different movements. And there's a couple studies that have looked at this. The practical example that I think of and how it was looked at during these studies is a squat with some resistance, and trying to determine if increased resistance increases the amount of that force through the patellofemoral joint, and in addition to that, how much knee flexion during the squat creates that peak joint reaction force. The first study was published in JOSPT in 2002. However, the problem with this is it was a really small sample size, only looking at a handful of females, so it was only females as well. And they found that there was no difference in the patellofemoral joint reaction force at 70 degrees, 90 degrees, or 110 degrees. However, it was later looked at by Cotter in 2009. He actually did his dissertation on this at Ohio State, and he found that with increased knee flexion, there's greater patellofemoral joint reaction force. He looked at it a little more thoroughly, so I think based on the information that we currently have, we're pretty safe to say that during a resisted squat, increased knee flexion leads to increased patellofemoral joint reaction force. Now, whether that applies to a patient's presentation of patellofemoral joint pain or not, it probably depends on the situation. If you do have a patient who is lifting heavily at work, repetitively, getting into a deep squat over and over and over again, it could definitely be contributing. If you have a patient who goes from doing no squatting activities to doing a lot of squatting activities, it could be related to their pain presentation. However, if you have a patient who doesn't really squat a whole lot, who doesn't do any excessive amounts of resisted squatting, then it's going to be hard to say whether or not that's actually associated with their symptoms. I would argue the majority of the time when we have a patient who's presenting with patellofemoral pain, if it's not acute and not a load management problem, then we need to definitely be taking a holistic approach using the biopsychosocial model to address the many different factors that could be contributing to their pain experience. One way you can think of the patella is that it acts as a spacer. It increases the internal moment arm of the knee extensor mechanism. And there's three factors that influence the length of the internal moment arm: the shape and position of the patella, the shape of the distal femur, and the migrating medial lateral axis of rotation. Something for us to consider during our observation during the objective exam would be these anatomical considerations. The Q angle, increased Q angle suggests greater lateral forces on the patella. Static and dynamic Q angles, so we're talking about this genu varum or valgum, and then hip muscle weakness. Now, we'll talk about these in much more detail in the later slides, but you've probably seen in the clinic how these things are often looked at and prioritized in some cases for the management of the patient's pain. And even before the management, really a lot of clinicians focus on these few variables to educate their patients on why they're having this pain. And I hope that we can demonstrate that we need to go beyond that and consider much more than just these observation characteristics. We can talk about all of these biomechanics, but I think it's important that we look at the reality of the biomechanics within patellofemoral pain. So we're going to look at what the evidence says about our ability to assess knee varus and valgus, structural changes and its association with PFP, biomechanics such as dynamic valgus and its association with PFP, and we're going to look at a current pain model for PFP. The reason I want to do this is there's a huge discrepancy out there between the biomechanical narrative and the current pain narrative on why people are having PFP. So we just looked at the biomechanics, and I think it's important that we have a good understanding of the biomechanics of the knee joint. But now we're going to look at what evidence is telling us in its relationship to pain presentations. First, I want to look at our ability to visually assess knee valgus and varus. We've referenced this study before, but I want to take a more in-depth look at it here because I think it's really relevant for this patient population. And this study looked at lower limb visual inspection. So 50 patients went through whole leg radiographs, as that's the gold standard to assess alignment for genu varum and valgus. And then after that, these different providers were given a picture of the patient, and based on that picture, they were to label them as severe valgus, neutral, moderate varus, or severe varus. And the conclusion showed that visual inspection is unreliable. Incorrect judgments from clinicians were made between 45 and 70% of the time. Women were at higher rates of incorrect diagnosis, and BMI, surprisingly to me actually, BMI did not increase odds of an erroneous assessment. You might hear in the clinic oftentimes observation becomes more difficult if there's a lot of adipose tissue, and this study found that there was no increased risk of erroneous assessments based on BMI. So you can see here, over 50% of the time, we're unable to identify the difference between severe, moderate valgus and severe and moderate varus. This next study we're going to look at is addressing whether or not those biomechanics and biomechanical changes are associated with patients who have PFP, specifically sitting pain with PFP. That's a very common complaint for patients who have PFP, so this study specifically looked at that. They had 133 participants split into 3 groups. Sitting pain after exercise, and no difficulty sitting. So when they came in for the study, they identified whether they had sitting pain, whether they had sitting pain after exercise, or if they had no difficulty with sitting. Once they got in the study, MRI was used to identify alignment and bony morphology of the knee joint and patellofemoral joint. And what they concluded from the findings is that there's no significant associations between the presence of sitting pain and alignment, morphology, or structural changes. There was limitation to the study. Obviously, they're just looking at sitting pain and not people with PFP in general. However, I think we can probably generalize some of these results to patients who have PFP. And we should understand that knee alignment, morphology, and structural changes are not associated with patients who have PFP. So we're unable to statically assess or observe these varus and valgus changes, and we also understand that these changes within the knee joint itself or static alignment changes are not associated with sitting pain for those who have PFP. But what about dynamic knee movement control? Specifically looking at dynamic knee varus and valgus. This systematic review and meta-analysis included 48 studies. 25 of those studies were specific to PFP, 15 OA, and 8 ACL. The results from the systematic review and meta-analysis actually showed there was moderate evidence that changes to knee and hip frontal plane movements were associated with PFP. So in the patients who had difficulty controlling their knee position in the frontal plane had increased risk for PFP. What was interesting is they did not find an association with transverse plane movement, so the rotational component of that varus and valgus was not associated with PFP. I know we're not talking about this right now, but I thought another interesting finding here was that evidence is limited and uncertain in regards to OA and ACL pain and injuries. So our ability to control our knee, varus, and valgus, there's limited and uncertain evidence in regards to OA and ACL injuries. Conclusion from the studies, or from this study, showed that changes in movement control is associated with pain and function in those with patellofemoral pain. So in the clinic, when we observe our functional assessments, when we observe them squatting, stepping up, stepping down, it is important for us to see whether they have the ability to control their knee position and see if they fall into a habit of going into dynamic knee valgus or dynamic knee varus. If they do, then our management strategies may change a little bit. Now that we have a good understanding of the role of the biomechanics in patellofemoral pain, I think it's important that we go beyond that scope and get a better understanding of what a current pain model for PFP looks like. The main takeaway is that the pathophysiology of PFP is complex in most cases. Biomechanics may be associated in some. However, we cannot reduce the patient's pain experience to faulty movement patterns or abnormal changes within the knee joint that you might find on an MRI. Instead, patellofemoral pain is often a nonspecific diagnosis. Acute PFP is typically a result of excessive loading. Chronic PFP is typically associated with various contextual factors. Like you'll see across the body, acute presentations may be associated with that loading difference or that loading problem that they've developed. Chronic diagnoses typically have many more factors playing a role that can be more challenging to address later on. The other thing to keep in mind is that when we're studying these patients, oftentimes experimental pain is different than what a clinical pain looks like. You can see in the top right picture here, during a lot of studies, a nociceptive stimulus is applied, whereas when patients come and present to us in the clinic, if it's not an acute presentation following an injury, it's typically a non-specific pain that there's no nociceptive stimulus being applied. So I think that's an important takeaway as well. If you want to learn more about a current pain model, just in general, looking at pain neuroscience, I would encourage you to read through these bottom two articles. However, don't be surprised if you can only understand about half the words. Pain neuroscience, there's just a ton of really big and confusing words. So they are a bit challenging to read through. I only understood about half of the words. But if you want to give it a shot, go for it.
Please let me know if you have any questions and feel free to contact me directly.